Hi, good morning, everyone. I welcome you all. I welcome the esteemed faculty, Dr. Rajiv Singla, Dr. Deep Dutta. I welcome Dr. Ajay Kumar Gupta, past president of IIT Delhi. I welcome Dr. Vipul Jain, the coordinator of this TIDE certificate course. And I also welcome all the delegates who are here to attend this seminar, the webinar. So today is our 7th session. We have already conducted 6 different sessions on different aspects of type 1 diabetes, and today we have the session number 7. And the topic today is very interesting and very felt need of the type 1 diabetes care, and that is the case-based evaluation of CGM and SMBG data. And we have the masters of this topic today as Dr. Deep Dutta and Dr. Rajiv Singla. And we welcome Dr. Rakesh Mishra. Dr. Rakesh Mishra is here. Dr. Rakesh Mishra is Professor of Pediatrics, Director and Chief Gastroenterologist and in charge Liver ICU at Chirayu Medical College, Bhopal. Welcome, Dr. Rakesh Mishra.
Thank you, sir. Thank you.
Dr. Rakesh Mishra is our guest faculty today, and he is a member of IIP, and he is eminent IIP faculty in India, and we welcome you, sir. And to start with today's proceeding, I will invite Dr. Rajiv Singla and Dr. Deep Dutta to start with the session on SMBG data and CGM monitoring.
Thanks a lot, sir.
Yeah, thank you. Yeah, so I think I think everybody's seeing me quite a lot in most of the sessions, but let me introduce Dr. Deep here, and then I'll talk a bit about the session So then a little bit about the session that we're going to take. So Dr. Deep Dutta is a very prominent endocrinologist at Dwarka. He was earlier faculty at Department of Endocrinology in RML Hospital, and now he has got his own center at Dwarka, and I think he's got the maximum number of publications. Maybe all of us put together will not be able to rival the number of publications that he has. He's an excellent speaker. So we are looking forward to a good session here. A little bit about session today. So what we are going to do in today's session is that this session is going to be is supposed to be more interactive in nature, and what we are going to do is I'm going to set the stage, then we are going to take 6 or 7 cases as time permit, and in each case we are going to dissect. If somebody comes to us with a particular set of CGM and SMBG data, what do we need to do about, and how do we go ahead and interpret that data? For that, what we are going to do is that we are going to present each case alternatively, but I would request all of you to keep on putting more questions in the Q&A, so that on each case, whatever your questions are, we are going to take that live. So there is any doubt or anything that you want to ask or add, please go ahead and put that in Q&A column, and that is active throughout the session. So we are going to take them each case by case basis as we go by. Yeah. So just to start with today's session, let me go back. I think we've already done a session on how to initiate insulin and how do we try to modify, set the basal dose and set the prandial dose, right? So I'm just going to give you very brief, in a minute's time, the brief about how do we go ahead and do it. So next. Yeah. So I think the first and foremost is that if any child with type 1 diabetes comes to me, the first thing that I ask them is that what we need to do is we need to start from their diet. Although once we've achieved our purpose, means that the child is well versed in the carb counting, in managing their own dose, so perhaps the timing becomes a little immaterial. But to start with, if the child has uncontrolled diabetes, the doses that we do not know, the ICRs are not yet set. So generally, I tend to start with simple things that to start with, at least let's fix the time and the pattern of diet first, which means that if we are trying to take 3 meals in a day, let's stick to the 3 meals. If we are taking some snacks in between, then we should think of either going with non-carb snacks, and or we kind of go ahead and take an additional shot for those snacks to cover those snacks with insulin. And then one also most important thing is that we should not push the child too much, in the sense that ideal may not be practical. We have to look at what is practical given child and the family circumstances, and sometimes something which is practical may be more useful in long run than looking for an ideal thing in the long run. Second thing is the exercise. I think we just to tell you about exercise is that exercise is not, in type 1 diabetes we are not trying to burn calories by doing an exercise. Exercise moves your GLUT4 receptors from cytoplasm to cell membrane just by exercise, and then action of insulin is bypassed, and then the action stays there for almost 36 hours or so, 36 to 48 hours or so. So basically, if you are exercising, then the stability of your glycemic control improves tremendously as compared to if you are not exercising at all. Generally speaking, the timing of the exercise should be set, and exercise again should be tuned for long-term sustenance and not so the child should not perceive exercise as a punishment. So whatever they like, they can do 1 hour a day at any point of time during the day. And then third thing is, then when we come is we start with setting the basal first. We have to set the basal first, and then we went through this, that we do the nighttime testing 3 or 4 times, and then we try and see whether our bedtime sugar is almost equivalent to what values do we have in the morning. That's what your basal is. And if your values are falling, then we need to decrease the basal dose. If your values are increasing in the morning, then we need to increase the dose to set that basal dose. As for if people are on insulin pump, then we can set the basal dose across each meal time. We skip that meal and then try and see whether our basal levels are being held or not. That's how do we do it in case of a pump. And then when we do in case of prandial sugars, we already know. What I would suggest is that if we have not set these doses for people, we can go it meal by meal. We can set the basal first, and then the breakfast basal, then we set the breakfast dose, then we set the lunch dose, and then we set the dinner dose. It can also be done in a different way, in the sense that if we believe that one meal which is ideally set, we can start from that meal. So if somebody's values are absolutely okay around dinner, so then that may be the meal that we set first, and then we go up to the breakfast, or maybe we can go back from there to the lunch, and then we can go to the breakfast. So it's not a clear rule, but basically we hold on to some baseline which is our fix, and then we try to correct all the values going from there. Yeah. So next slide first. So next slide. Yeah. So now coming to the core topic for today's talk. So whenever somebody comes to us with either their CGM data, which is a continuous glucose monitoring data, or they come to us with their SMBG data, what we do is we evaluate them in a very, very structural manner. So what we've done is that and these are not clearly rules which are prescribed by any guidelines, but this is what we generally follow, or me and Dr. Deep follow in our practice, is that we ask these questions in exact this sequence to ourselves. We look at that CGM or SMBG and ask ourselves, is there any pattern at all? So we are not looking at individual value. I don't look at some value which is 300 and try and think whether I can correct it or not. We are not yet there. We ask ourselves, we look at CGM data for multiple days, at least 4 to 5 days at one time. and then try and ask ourselves, is there any pattern at all in this data that is in front of me? Once I see there is some pattern, then I ask myself, is the basal dose correct? Am I looking at a chart which tells me that the basal dose is correct or not? Because that's my first step. I set the basal first. So I look at that thing first. Is my basal dose correct or not? Once I am sure that my basal dose is correct, then I go to the next question. Can variations be explained by variable physical activity, in the sense that we are doing physical activity one day, we are not doing physical activity the another day, things like that? And can these variations be explained by intermittent eating, which is not being covered by insulin? Are snacks being covered by insulin or not? Then we go to the last thing, which generally in practice we tend to do first, that we see a value of 300 and then we go ahead and decide, okay, let's increase the dose. That's the last thing that we need to do. Does bolus dose needs adjustment at any meal? If yes, check if bolus dose is being taken after calculating carbs and is not empirical. That's very, very important, because generally what happens is that we look at a value 300 and then we increase the dose itself. But again, we have to look at pattern. Is our dose insufficient or in excess at same time every day or not? If it is not same fall or same rise every day, then we really need to look back and think as to why this variation is being there. And then once we've gone through all these questions, then we look at some actions that we can take based upon this. So if there is no pattern at all, which means that our type 1 diabetes is just being managed very, very empirically. We are just looking at sugar values, and then we are giving insulin dose empirically. Okay, my sugar today is 200, maybe I should take 8 units today, and tomorrow if it is 70, maybe I should just take 2 units. So there is no structure, there is no objectivity to it. We are not trying to match our insulin with the diet that we are taking. So what we need to do is we just need to start afresh. We need to start diabetes education of the child and the parents or the caregiver, and then we restart everything. Then of course we analyze the data, but as a rule we correct hypoglycemia first before hyperglycemia. If your chart in front of you has any value which is less than 70, that is what your starting point is. We correct that, and then we come back to higher values, and then we correct it, right? Third thing, again, it cannot be overemphasized, is correct your basal dose first and start correcting from a data point where blood glucose values are already in range. That also generally is a good idea. So these are the basic structure. And now what we are going to do is we are going to analyze each and every case that is going to come forward in the similar manner that we've asked here. So now I would ask Dr. Deep to please go ahead and start with your case 1.
Thank you, Dr. Rajiv. You have beautifully summarized the structure we need to follow. Ultimately, this structure helps us in managing difficult conditions. Otherwise, we would be totally lost in the so many data points in a SMBG chart or a CGM chart. So this was already covered in last presentation. Let's summarize again. We have this CGM chart in front of us for 5 days for one child. So we just look at it. The time in range has been set. In this chart, it's the gray point of the curve, which is 80 milligrams to 140 milligrams per deciliter. You may choose to keep between 80 to 180, whatever you want. So net point, we get some percentage values in the graph on the side, and we see that we want more and more numbers to be in the gray zone, which is the time in range zone. We definitely do not want any values in the red zone, which is less than 80 or 70 milligrams per deciliter, which is the hypoglycemia. And that should be the starting point of correction, as Dr. Rajiv just told us. And then comes the yellow point, which are the time above range, which is more than 140 milligrams per deciliter in this chart. So as Dr. Rajiv said, let's try to look at some pattern. So we are not looking at individual values. We have 5 different days charts here. So can we see some pattern here? If one pattern which we can somewhat, if you really like to say, is that the time of the day the blood glucose tends to be lowest is usually anywhere between say 1 a.m. to 6 a.m. in the morning, that too on 2 days, only on Friday and Saturday. Then something happened on Sunday, everything is above time above range. So there was a small hypo on Saturday, there was a good range on Friday, and Sunday and Monday totally different, all the time in hyper. So we really do not have any structured fixed pattern. But one thing is for sure, entire day is bad. From post breakfast, pre lunch, post lunch, evening, everything is high. So maybe this child is under insulinizing, they are rationing insulin. That may be an issue, and we need to find out what happened on Friday and Saturday that the blood glucose went low. Did the child exercise? So next question was physical activity. Did the child exercise in the evening? Went for a football class, badminton class, and that led to a greater GLUT4 expression and greater absorption of glucose into muscle, adipose tissue, and liver. Maybe the child didn't exercise at all on Sunday, on Monday. So we need to sit down. We need to keep these points in our mind and ask specific questions to the caregiver and the child to find, because unless we answer these questions, there's no point of just changing the dose of insulin. So
So
yeah, Dr. Rajiv.
So Deep, I was kind of trying to ask few questions from you. So just to discuss this case, I think
Yes.
what I believe is sometimes, of course, that's the most important thing to ask children or their parents. But what I've realized in practice is that unless we ask them very specific questions, the answers generally remain always vague, right?
True.
So few things that we need to keep in mind while we are analyzing the CGM is that I generally what do is that I keep Saturdays and Sundays. I always look at a different pattern on Saturdays and Sundays, because what happens is that the Sunday night or the Saturday night may be different for a lot of people, right? So that's why if you look at this chart, so generally what I would say is I will try to look at weekends differently and weekdays differently, and then I would try to look at pattern among those two things. Uh, Second thing is, in this graph, if we really, the way I look at whether there is a pattern or not is what I would try to do is, in my mind, I would try to overlap the curve of each day, right? So the values are, whether those values are high or low really doesn't matter. What matters is whether these values overlap with each other or not.
True.
So in this graph, if we leave Monday apart, if we just look at Friday, Saturday, and Sunday, although Sundays, all the values are high, but if you try to overlap Friday, Saturday, and Sunday, so the curve would actually overlap with each other for large part of the day. So I would tend to argue in other way and try and say that to me there seems to be some pattern here. The one thing that I see in this chart is that the values are always high at 12 o'clock in the night, and then values are going lower
Yes.
at 6 o'clock. So
At
if
the
I
start
ask
of the day.
so if I ask myself a second question, is my basal dose correct? I would tend to say perhaps my dose is more. I need to reduce my basal dose, because from 12 o'clock in the night till evening, till early morning, sorry, only my basal is working, and that my basal is every day falling. If I'm starting from 160 or 180 perhaps, then it is going down to 80. If I'm starting myself at 280, then it is going down to 180. So it is almost 100 points fall every night. So I think first thing that I need to do in this case would be to reduce my basal dose.
Slightly.
Second thing, I think what is happening in this case is, because the child's early morning values are low, they are under dosing themselves for the pre-breakfast dose. That my values are coming 60 or 70, I only took 2 units. So, and then the values start going up, and then they are not correcting themselves for their values. So then it keeps on, even if their dose is like okay for few days, then because it's a residual thing which is not covered from the breakfast onwards, so the values start going up. So perhaps in this case, what I would do is at the minimal is I would reduce basal dose and then maybe increase little pre-breakfast dose and tell them that don't try to reduce breakfast dose too much.
True. Absolutely. That's a very rational way of putting it. And we always tell a patient, don't react, because if my morning glucose is low, that is not because of the morning insulin, it's the night insulin which has done the job. So if you need to correct, we reduce the basal dose in the night. That's very beautifully summarized our first patient. Let's move on to another set of patterns here. So, Dr. Rajiv, what is your take on this patient, the second child in front of us?
Yeah, so again, Dr. Deep, if we see the thing is same, so we ask same questions. Is there a pattern in this case? The way to look at this thing again is if you look at this is another child, right? So if you again look at it, the pattern varies on Sunday. But if I try to overlap my curves on Friday, Saturday, and Sunday, they would by and large cover each other. But what is happening in this case is my to answer to my next question is my basal dose correct? Now we are going in exactly opposite direction. My values are lower at 12 o'clock, but then they are increasing up.
By five
What
o'clock.
is at 5 o'clock, 6 o'clock? So my values are continuously going up in the night, right? And if I try to look at all my pre-meal doses, my curve is pretty flat. So if my pre-breakfast is high, my pre-lunch is almost at same level as my pre-breakfast is. So my dose is actually correct. Even if my pre-lunch is high, I should not be increasing my pre-breakfast dose here. Thing here is if my pre-breakfast value comes down, there is a very, very high possibility that my pre-lunch value would also come back to normal. So what I do in this case is I increase my basal dose, which is going to bring the entire graph down. I will not have this nighttime high. Only second point is that there is some peak at around 5:30 or so, specifically on Saturday and Sunday. But the same peak also is there on Thursday from whatever small data we have. So now this small rise can be because of some snack, or it can also be because of some physical activity. Now, it does not look like that snack is not being covered by insulin because the value goes up and then comes down. And it's not a very large excursion. So it is being covered. And the values are coming back to baseline. Once our all values are correct, perhaps we would be able to comment more. But it can also be because of physical activity. The reason being, if we are doing some intense physical activity, our blood glucose values go up, but then they come back with same speed. So it can be some physical activity, it can be some snack, but I would not like to do anything about it at the moment. At the moment, I would just like to adjust my basal dose first. I am going to increase it by 10% increments every third or fourth day till the time my 12 o'clock and 6 o'clock values are almost same. That's what I'm going to do. And then I'm going to reanalyze in similar way and then try and see where do we go from there.
Amazing, amazing. So beautifully summarized. Maybe the Sunday was the child didn't exercise the Saturday evening. Maybe went out with friends, no school that day. Maybe that's why
Yeah,
we didn't have a 12 a.m., that 11 p.m. to 12 a.m., 1 a.m., a slightly dip in the normal range. That didn't happen on Saturday night to Sunday morning. So these
absolutely. Saturday night, late night snack, or we ate something, we stayed up late, we ate more food. So there can be so many reasons for this pattern, but we would commonly see that weekends are different.
Yes, great, great. So moving on from two scenarios, first a patient, first child, we had to reduce the basal insulin from the chart. The second child, we realized that we were underdosing basal. We can improve looking at the whole nighttime pattern. From that, let's move on to this third child here. We again have two values of weekend, Saturday, Sundays, and three weekday values, Monday, Tuesday, and Wednesdays. If we look grossly, if we try to, as Dr. Rajiv said, reimpose or superimpose all the 3-day graphs with each other, if you see here, we are seeing a lot of yellows at around maybe pre-lunch to post-lunch areas. It happened at least on Saturdays and Sundays. Mondays too, it's there, but lesser prominent as compared to Saturdays and Sundays. But then something happened on Tuesdays. Tuesday, no bumps, no yellow areas in the pre-lunch, post-lunch areas. Now that big bump, that the yellow area, the surge is there in the evening, around 6 to 7 p.m. in the evening. And if you see here, that hyperglycemia in the evening area on Tuesday was not at all there on Monday. Monday, in fact, the child had a hypoglycemia at the same time around 6 to 7 p.m. in the evening. And if you look at Wednesday data, or the 3 weekdays data also, they're different. Wednesday, somehow on a pre-lunch, the child had a hypo. So what we understand, there's a lot more variability in this child as compared to the previous two child we have seen. So this is, although if you just look at the gross values, you will see that the time in range targets are more in this child as compared to the previous two child. If you don't see the graph, if you look at just the values, you will see this child is doing better. But once you look at the graph, we actually see this child has more variability and this child is actually doing worse and is perhaps a more difficult child to manage as compared to the previous two children. So
Oh,
Dr.
absolutely.
Rajiv, what is your take from here?
So I think a couple of things here in this graph that I can see is one, that it seems clearly there is no pattern here.
Yes.
The child needs a structured education. We are looking at all weekdays, and all weekdays looks absolutely different. So obviously there is a problem, right? If however I have to gain something from this chart, I would gain, as you rightly said, that this time in range looks more in this child, but at cost of more hypoglycemia. The graph is running almost at 80 line, which means that this child, to me, looks like is overdosing himself or herself, or the parents are trying to control sugars by giving more insulin. If we try to look at the basal dose, it again looks very high. Whatever we start off at 12 o'clock generally comes down by the time in the morning. So, and then there are hypoglycemia some day at 11:30, some days at 7 o'clock in the evening, and another day the hypoglycemia is there at 8 o'clock, starting from 8 o'clock, and then it goes there. So there is absolutely overdosing here. So we need to reduce basal. We also need to tell the child that, or the parents, that don't react to the values. What is happening here is that if the values are very low, then perhaps insulin is not being given, or very low values are being given. And when it is high, then the overdosing is being done. So we need to sensitize them that reduce the dose, let values be little high for few days, and then we'll bring it down in a structured way.
Great, absolutely, yeah. So then we have the fourth child here. Again, we have 5 graphs we have from Sunday, Monday, Tuesday to all the way to Friday. Again, the first thing we do, we try to superimpose the graphs here. Something what we can understand here is happening from morning, say around 8 a.m. to entire day around 4 in the evening. Keep the Sunday apart. If you take the weekdays, Monday, Tuesday, Wednesday, Thursday, things are going really haywire from when the child goes to school, is in the hyperglycemic state, comes back from school also in the hyperglycemic state, maybe has a lunch and he takes a good amount of insulin. So somehow by evening 4 o'clock or 5 o'clock, it slightly tends to come down, but still it is in the hyperglycemic range. So maybe the child is having a good snack at school and is not taking the insulin shot with the snack at school. Maybe the carb content of the meal is pretty high in the school. And Sunday, if you see, the child was at home, so no chance of missing insulin. So any Sundays, I think the day, we're only looking at the day part. Although that is wrong, I should have started with the hypo part, because we always correct hypo before looking at the hyper part.
Absolutely.
So let's start the hypo part now. So if you see here, the child is having a lot of hypos, be it weekdays or weekend. And unanimously, if you see here, anywhere in the evening from like 7 p.m. in the evening, all the way down to 1 p.m. or 1 a.m. or 2 a.m. in the morning, child is persistently having hypos, spending a lot of time in hypos. So what is happening here, we need to look at it. Is the child exercising? Or because we don't expect hypos right at maybe 7 or 8 p.m. because we usually don't give basal insulin that time. So the hypos is starting even before we are giving the basal insulin. So something is happening. The child is exercising at 4 or 5 in the evening. So we need to find out what exactly is causing it, and that is further accentuated as the whole night goes. Another thing which would contribute to the hyperglycemia in the morning is the Somoyagi phenomenon. The long time of hypo in the night will lead to release of counter-regulatory hormones, and that pushes up the blood glucose in the next 6 to 8 hours. So, Dr. Rajiv, your take now from this.
Yeah, so okay. So before I explain this, I would again ask audience to please send their questions to any case right away so that we can take them up along with as we kind of go ahead and discuss. So, Dr. Deep, for this case, I think you already explained everything. However, just to kind of give it a structure, is there a pattern? There is definitely a pattern. These are clearly overlapping graphs over each other. And I think you rightly said that this is one of the graphs where we want to explain that hypos need to be treated first. If we look at this chart from the perspective that the first case we discussed, our first interpretation can be okay, the values are going high from 12 o'clock till 6 o'clock in the morning. So my basal is lower. But that's not the correct way to look at it, because what we are starting is, if we start doing that, then we are missing the hypoglycemia. What we can see here is that the child is into hypoglycemia clearly, and then there is something called hyper roller coaster, as I call it. If somebody's got into hypoglycemia, then body goes into overdrive of gluconeogenesis and glycogenolysis. So this is not inadequacy of your basal dose, but this is overactivity of your liver and kidney, because your body perceives hypoglycemia as immediate survival threat. So unless you take care of this hypoglycemia which is happening at 12 o'clock, however dose you may increase, your hyperglycemia in the morning is not going to go away. So what you need to do here is that you need to cut down on your dinner dose. You need to cut down on your basal dose. Let these values a bit high and then start from there.
Great, absolutely. So now moving on from CGM values, where we have the luxury of so many data points to work and look at the pictures. Now we have lesser points. We have SMBG charts. This is the blood glucose values of a child who has predominantly checked the fasting blood glucose values, the pre-lunch blood glucose values, and pre-dinner. And then there are two post-lunch blood glucose values with us. If you just scan the values, forget the insulin doses, just scan the blood glucose values, what we can unanimously see is that the fasting blood glucose is very high. It's 270, 300, 245. The best case scenario was on one day, which came down to 148. That's the lowest fasting blood glucose we have. If we compare the pattern with the pre-lunch and pre-dinner, pre-lunch tends to be slightly better as compared to fasting glucose values for a few days, but then on the day when the fasting glucose was 148, pre-lunch we have shot up to 260. The next day was 175, 245. So pre-lunch is also equally bad, if not better. It's bad only. The least bad of all the three would be the pre-dinner values. We are just looking at the pre-meals for the simplicity now. And they tend to be best of all the three pre-meal values. And what is important now, if you look at post-meal, we don't have any post-breakfast, but post-lunch, the child is definitely going into hypos. So this child is not doing great in terms of blood glucose control. We have been taught fix the fasting first. So we need to ask more questions. What's happening? Is the child having a hypo later in the night? So we would request the child to check a post-dinner value if the child is awake. If the child goes off to bed, maybe request the parent to wake up the child by 2 or 3 a.m. if possible, and check that midnight. We want to rule out Somoyagi phenomenon first. And if you see few values that the post dinner is also high and the 2 a 3 a.m. is not low, it is on the higher side, then there is the inadequacy of basal insulin. We can safely increase the basal insulin to fix the fasting glucose. And we expect, as Dr. Rajiv said in the previous two, patient number 4, if I'm not wrong, you fix the fasting, your pre-lunch comes under control. There is no point of increasing the morning short-acting insulin glucose values to control the pre-lunch. If that is the scenario. But what is important here is that at least we have some information to show that the pre-lunch bolus insulin is overworking. We are having post-lunch hypos at least. So if at all something we need to reduce the pre-lunch bolus insulin. And then Dr. Rajiv, anything I missed out? Your take on this?
No, I think that's absolutely what it is. Before, like, in this chart, I would say in a normal common practice, what would happen is that it will end up child with more basal insulin in the night, which may still be required in 70% of cases, but in 30% of cases, we know that it can be a Somgui phenomena. Child may still be having hypoglycemias in the night. The clue to that would also be if you look at the fasting values, two highest fasting values, 270 and 290, are preceded by 115 and 123 values pre-dinner on the previous nights.
Yeah, that's a great input.
So then there is a very, very high chance in this case, we really can't rule out that the Somgui phenomena is not happening. So before we tend to increase any dose, we check it at 2 o'clock or 3 o'clock in the night. But I think rest of the things are okay. I think breakfast dose looks okay. Apart from one couple of days, our values are either going down or are staying same, which means that our breakfast dose, both correction and the bolus dose is kind of is correct at the breakfast. Lunch, as you rightly said, I agree with you that seems to be little over, but because dinner values are also okay for most of the time, we also need to inquire whether there has been some specific things on those two particular days, because if the child has checked only for 2 days at evening, which means that the hypoglycemic symptoms were only there for these 2 days.
True.
So maybe it is not related to dose. Maybe it is related to physical activity or the diet was less. Dose was still taken same, right? So that's how I would do it in this case. But yeah, that was the point that if we have SMBG, don't jump to the increase in dose again. Try to go deeper, look at the cause, what is causing it, and then we go and increase the dose if needed.
Great, wonderful inputs. Now let's move on to another child here. We have a sixth child here with us. Again, we have now more charts to work on. If you have the charts all the way from
Deep, I think we should skip this case. This is a little more complicated, and I think we are overshooting our time here. So let's go to the next case. We'll do that case first.
Okay. So next case is more simpler. I think we have less data points to work on. I think here also we have SMBG values here. And again, if you see here is, we look at the fasting blood glucose first, and we see that we are not doing great. The lowest is 149 here, and often it is crossing 200, 250, 260, 244, 293 also we have. So yes, we are starting the day badly. Moving on to the pre-lunch, if we look again here, things are not becoming too worse actually. They tend to remain the same, 214s, once 279, but that day fasting was 260, so not much of a change. In fact, some days the pre-lunch tends to be even better than the fasting blood glucose. Only on one day it went from 149 to 289. Except that day, all the other days the pre-lunch tends to be better or same. As compared to fasting blood glucose values. The third value, if you see, compared to the previous SMBG chart where the pre-dinner tends to be the best part of the day, here the pre-dinner is also equally bad or even worse actually. We are even crossing 300, 364s and 319s we have, and the best pre-dinner value was actually as high as 181 only. So entire day is bad. Bad fasting, slightly equally bad pre-lunch, and even worse pre-dinner. That's the take-home message we have. We don't have any post-meal values to work on here. And so I think Dr. Rajiv, from here, with this points, what is your take? Where do we go from here?
So I think Dr. Deep, in this case, there does not seem to be any pattern in this value.
True.
Right. The another thing that we need to see is that if you look at dinner values, you see the child is taking as much as from 9 units to 20 units, which is little too much of a jump for us to be taking, right? By any calculations. So, and if you look at first 3 days dinner values, so they are almost similar, 181 and 198, right? But the next day post breakfast are 3 different values ranging from 150, 350 and 190. So kind of that tells me that everything is being done ad hoc here. There does not seem to be any pattern. We have to have some baseline established, and this child just needs education, and some system need to be this case need to be start afresh.
Yes. Fix the fasting first and start afresh. A lot of work remains there. eighth child for us. Now we are back to CGM graphs. Again, gray areas, red areas, and yellow areas. So here is a child, just one look, at least we don't have any red areas in front of us grossly. We have lots of yellows in here. So the child is predominantly spending most of the time in the hyperglycemic, just one glance. Next step, we try to superimpose the graphs. We keep in mind Saturday, Sunday, the first 2 days are weekends, and Monday to Thursday, we have the weekdays here. And if you see here, if you really like to bring it back, anytime the child is having slightly good blood glucose control, that tends to be usually in the evening, slightly coming back to normal. Apart from day, there is some early morning, there is some shift here. So again, this child is predominantly in the hyperglycemic range. So Dr. Rajiv, where do we go from here?
So I think in this case, Dr. Deep, if as you said, I think what we need to infer in this case is that, as you rightly pointed out, that the values are going lower at around 10 o'clock in the night. What I believe in this case is that although the graph seems to be flat, set at a higher level during the night, but I believe in this case, we still need to increase basal dose bit by bit, because that works your 24 hour. In this case, everything kind of brings down, but at the same time, we definitely need to decrease the pre-dinner
bolus.
Pre-dinner bolus. So we decrease the pre-dinner bolus, but then we gradually increase basal, still looking at relationship between the 12 o'clock and the fasting values. And then I think just tweaking small amount of basal dose and the dinner dose can bring this entire graph down. And then we also need to take care in this case, as you said earlier, is that our range is set here at 80 to 140. We need to really be setting it at 80 to 180. 70 to 180 is what our target in range should look like. So if we increase it, so a lot of this yellow area would get covered into the gray, right? So we increase just little bit of basal, decrease dinner dose, and then we start all over again. That's what I would do in this case.
Great. Absolutely. Start low and. So I think time to take questions. We have covered different scenarios from somoyagis to persistent nocturnal hyperglycemias to hypos to different patterns on weekdays and weekends. So we can take some questions now. Do we have, let me see the chat box.
No, I don't see a question there.
Dr. Mishra, sir, are you there?
Yeah, there's one question now. So in the meanwhile, let me ask, there is an audience question. What do we do for dawn phenomena? That's a great question.
So I think we covered here. It just tells us that the basal insulin dose is inadequate. There is basal insulin dose inadequacy. So we slowly build up the basal insulin, and that would result in fixing the fasting glucose. We do not touch the other values. We hope that the rest of the values would fall into place just by slowly increasing the basal insulin. That's what we're trying to do. So we are sure it is not Somoyagi. We are sure it is dawn phenomenon. The challenge is to find out which is dawn and which is Somoyagi. That's a difficult job.
Let me make this question more difficult for you, Deep. So my bedtime values at 10 o'clock is say 140. My 230 value is again 140. But my pre-breakfast or the fasting value at 7 o'clock is 180. What do I do now?
Yeah,
if I increase my basal, my values would dip in the night at 2 o'clock. So this does not qualify for a Somgai phenomena. This is a true exact case of dawn's phenomena. Everything is stable. In early morning, because of my hormonal surge, 3 o'clock my value starts going up. But in few cases, that's an exaggerated response. And my values are like, say, 180 at 7 o'clock. How do I handle that?
Yeah. So we need to as a child, 7 o'clock when you're checking the blood glucose, is it just like you're waking up, you are still in the bed, you checking the blood glucose and coming out of the bed? That would be totally different interpretation from like I wake up at 6 a.m., I go for a morning walk or a jog, and then I come up and check my blood glucose before maybe having a bath and going to school. So that would be because if it is post exercise, we know that immediately post exercise the blood glucose goes up. So we tell the child, please don't check at 7, please check at 6 a.m. when you get up from bed. That should be good enough in that child.
Absolutely, absolutely. And I think in a true case of, say, if we've ruled out all these logistical issues, so like the child is doing it right at the bed and everything, and it's actually because of hormonal surge, which we see in few cases. I think those are the cases which are very, very difficult to handle. Let me be this thing clear about this. Only ideal way to treat in that case would be an insulin pump, so that I can change my basal dose at 3 o'clock in the morning, and then I keep it down there. Short of insulin pump, uh, I think the ways to go about all these things is, sometimes few things happen is that we introduce a bedtime snack and we increase the basal dose, so that I prevent 2 o'clock hypoglycemia, but my morning surge is still covered by basal dose. Few people tend to, in few cases, for me it has worked, is that changing the dose of basal also works. Like if some few childs are taking Lantus glargine in the morning, so because the 24 hours it is not working for 24 hours, so then my early morning surge may be there. So shifting my basal dose from morning to evening sometimes does help in these cases. So that's the second way to handle it. And so I think these are the ways to handle it, but ideal in this case would always be an insulin pump that's there. Okay, so second question for you, Deep, is how much increments or decrease can be done in the basal dose?
Yeah. So I think, as you said correctly, that we do it very gradually, no drastic. If we have seen the last child, he had gone from 9 to 20 in over a period of 2 days. I mean, that is, we never do in our practice. We do subtle changes of 1 to 2 units per day, and see the pattern and then work on it.
Yeah, I would absolutely agree that. Rather, I would say I would arrow even on more conservative side. I would say increase 2 units every third day or so.
Yes.
It's a long-term setting. It's not a
Yes.
one-day setting.
True.
So I tend to be even more conservative there. Okay, so can you please name the brand used for basal and bolus?
I think it's not important brand. The brand is not important at the end of the day.
Absolutely.
It is what insulin we are using. I mean,
Absolutely.
glargine works great for a majority of your kids. In some kids, as you just said, if you give glargine in the morning, it doesn't give a 24-hour coverage. You can switch to an ultra long acting basal insulin, or even better, shift glargine in the evening. That should do a better job.
Yes. Yeah, so I think maybe the user wants to ask is analogs versus regular insulin. So what's your take on that?
So the take here is, again, it is highly individualistic. There are certain advantages of regular insulin as compared to ultra short acting analogs, especially in a school going child. We have seen often if a patient is not on pump, and the regular insulin tend to give a slightly better coverage during the school days, school hours, as compared to maybe the analog insulin. So it's highly patient centric. To say that one is better would be absolutely wrong. Only case where would be like toddlers with diabetes, where the parents are really worried whether the child will eat or not. You really want to give a short acting bolus after the child has eaten something. Looking after doing the carb count, you may use the ultra short acting analogs like the URLI insulin, ultra short acting Lispro, or ultra short acting Aspart. Otherwise, there is no difference.
Right. Yeah. Okay, so then Dr. Amit asks, in which situations do we give basal in the morning, and when we prefer basal at bedtime?
No, we traditionally are giving basal at bedtime only. In only those kids where specific challenges, we are having intractable hypos, we have tried out the best and it's not working. If certain parents have phobias, they have phobias that we don't want to give, we are fearful of a hypo in the child, whether my child will collapse or not. In those cases, we end up giving the basal in the morning. Only the ultra long acting basals like the U300 glargine or degludec gives us an option that you can give them in the morning and or in the evening. They tend to have a better 24-hour coverage. If you're using glargine, we typically give at bedtime only. We don't start glargine in the morning typically.
Right. Yeah, so I actually, Deep, I have a theory.
Mhm.
And then you can ratify it. I think this nighttime of basal dose came from the fact that I think people realized very early on that
Mhm.
glargine does not work for 24 hours. So
Mhm.
if I'm giving it in the night
Mhm.
and it stops working, say at 8 o'clock in the night, say I'm
Mhm.
giving, we typically tell people take it at 10 o'clock or 11 o'clock,
Mhm.
and say it stops working at 4 hours, 3-4 hours before that,
Mhm.
then I can still cover that time with my dinner dose,
Yes. Yes.
right? So that may be the sense. Typically, in the morning, we give it for elderly people who are living alone. That's not related to type 1 diabetes. So that's the time using basal dose in the morning.
Mhm.
In somebody for for whom the glargine is working for 24 hours, it
Parag.
really does not it really does not matter.
True. Fully agree
And,
with you.
and as
Absolutely.
you rightly said, that degludec and U300 insulins, now we do not kind of matter whether you take them in the morning or evening, irrespective of what time we do it.
Agree with you. Absolutely.
Yeah, I think no more
Uh,
questions here.
we have more questions on this. We have Dr. Vikas Barotra. Dr. Vikas, are you here in this webinar?
Yes, sir. Good morning, sir.
Dr. Vikas, I would like to know your inputs and your expert comments on the complexity surrounding this continuous glucose monitoring and self-monitoring of glucose.
Good morning, Dr.
Hello,
Mukesh.
sir.
Thank you for giving me the opportunity. It was a very nice discussion. I have been a part of it with Dr. Rajiv and Dr. Rajiv Singla. Sir, this my 2-3 point to be taken by each and everyone who is taking care of type 1 diabetes. Number one, if you start the therapy, and if you can afford by your rent or by some means, then you should always try CGMS first to know the basal requirement of a child. Because as Dr. Singla has very rightly said, sir, I am audible.
Yes, you're
Yes,
audible.
sir, you are.
As Dr. Rajiv Singla has very rightly said, the right basal dose is a foundation of successful type 1 diabetes outcome. So if you are using CGMS to find out the basal dosing of the child, it is excellent work. First of all, and then subsequently you can fine tune the doses depending upon the weekly or fortnightly CGMS along with the SMBGs. This first step. And secondly, as Dr. Deepdas has very beautifully depicted, we should go very gradually, addressing hypoglycemic events first, followed by hyperglycemic requirements. And then, if you have a beautifully designed basal dosing for a child, believe me, the chances of getting hypoglycemia are very negligible, first of all. Secondly, as far as CGM is concerned, there are parents who are using Libre very frequently in my clinical practice, and unfortunately, Libre are doing haywire, especially in the case when we need it the most. When the sugars are going very high or very low, Libre are haywire. So I always request them to kindly do the blood sugar before taking any clinical judgment or before taking insulin or dropping out insulin. So SMBG remains the gold standard for clinical judgment in an emergency situation. Dr. Singla, am I right?
Yeah, absolutely, sir. Absolutely, sir. I would
What is
I would
happening is,
just add.
just let me finish.
Yeah, please,
I have seen
please.
I have seen sugars are going haywire when we need it the most, especially in hypoglycemia and hyperglycemic emergencies. So never take clinical action depending upon your Libre reading uh, by decreasing or increasing insulin dose, especially when you are in doubt. Always check your blood sugar. Your take, sir. Your take,
No,
Dr.
no, I
Rajiv.
agree. Yeah, I absolutely agree with you, sir. There is no doubt that in case of an emergency, we just need to rely on SMBG readings, not on CGM readings. My two inputs on this thing is one, that this CGM especially does not work for us in Indian summers. What I've seen is that in summers, the values are consistently lower than what your SMBG would tell. So what I tell people is that for first 1 or 2 days, even when you put CGM, you need to cross check with your glucometer with each and every new sensor so that you know what you are dealing with.
Sir, I have got one study. I have conducted around 50 patients in my centers. I have tried different CGM. One is from Medtronic, other from Libre, and third from Dexcom. So the study is still going on. What I find is across all the things, Dexcom is very, very accurate. Although availability is the issue, and the cost is the main issue. But if you cross-check the interstitial sugar versus blood sugar, the Dexcom readings are more reliable, and Libre is a bit lacking behind as far as the gap between the interstitial sugar and blood sugar is concerned. But still, the gold standard remain is CGMS is for trends. CGMS is for trends. Analyze the trend, sit down with the parents, and decide about the doses. Basal first, hypoglycemic event first, and then gradually fine tune and gradually, taking your HbA1c from 8 to 7, rather to better control to best control. And this should be the take home message for every parent that, okay, 8 is fine, but we'll try for 8-7. The aim is to provide physiological insulin replacement therapy. Every word is important. Physiological insulin replacement therapy with optimizing the psychological and physical development of child without hypoglycemic events. That is my take, sir. CGM is a very important tool, but we need to have clinician, we need to train practicing pediatrician who can analyze the curve, and most importantly, who can devote their time to the busy OPD schedule to the parents. Time is very, very important. Dr.
Thank you, Dr. Vikas. We have Dr. Rakesh. Mr. Dr. Rakesh, are you here?
Yes, sir, I'm here only. Yes.
Dr. Rakesh, we would like to know your inputs on today's session and this CGM and SBMG data. Okay, I think sir is not reachable. He's here.
I'm here only. Am I audible, sir?
Yes, sir, you are audible.
Yes, sir,
So,
you are audible.
I would like to congratulate Dr. Singla and Dr. Deep for such an enlightening session. And having worked at AIIMS Delhi with the likes of Dr. Anup Mishra and Dr. Anurag Vajpayee, I have seen the nitty-gritties of adult as well as pediatric endocrinology. And although I find it very intimidating being a pediatrician. So congratulations to the panelists and the experts. As a pediatric gastroenterologist, I would like to ask the experts, how many cases you see of diabetes mellitus type 1 or even type 2 from the ped gastro cases like celiac disease or chronic liver diseases, and now as a lot of patients are undergoing liver transplantation. So are there challenges in the diabetes management of these kids?
May I revert, Dr. Mishra? Namaskar.
Yes, most welcome, sir.
मेरा भोपाल से बड़ा लंबा नाता है. मेरा बेटा वहाँ GMC में है फर्स्ट ईयर में. मेरी वाइफ भी GMC के हैं. So, Dr. Mishra, there are 2 points to be taken by every practicing pediatrician. To start with type 1 cases, if you do the antibodies, like GAT positive is there, anti-insulin antibody is there, simultaneously in a lot of cases we have got IgA TTG positivity without any clinical feature of celiac disease. It is all because of the cross reactivity of the antibodies. So the gold standard remains the duodenal biopsy. And if you follow these TTG antibody level, and if child is not symptomatically fitting into the celiac disease, so a lot of false positive cases are there, which are not turned out to be celiac. But on the contrary, let me finish, sir. On the contrary, 4% of the cases, they are celiac with type 1 diabetes. It is in our clinical practice seen. So a lot of cases of type 1 diabetes has got falsely positive TTG positivity, which has to be taken care by duodenal biopsy as a gold standard first. Secondly, every year we recommend that every child of type 1 diabetes should be taken care of by TTG as well as TSH because of autoimmune phenomenon going on. Thank you, sir.
Dr. Rajiv, would you like to add something more to it, or?
No, I think Dr. Vikas has put it very, I think aptly from diabetes and from celiac disease perspective. I absolutely agree with it.
And for
बहुत सारे बच्चे सर आते हैं
post-transplant
TDE
patients,
positive. Dr. Mishra,
are you
please.
seeing post-transplant patients coming? I mean, having diabetes pre-transplant and post-transplant, and what are the specific challenges along with immunosuppressants?
No, sir. You have to come across such cases.
Right. Thank you so much. Thank you so much.
मिलता हूँ डॉक्टर मिश्रा भोपाल आऊंगा तो मिलूंगा आपसे.
Sure. Most welcome, sir. Do let me know.
Thank you
It'd
so
be great.
much. The topic today was complex on like continuous glucose monitoring and self-monitoring of blood glucose data. But our distinguished faculty, Dr. Deep Dutta and Dr. Rajiv Singla, both very good friend of mine and living in neighborhood, made it very easy, and the topic was very informative and very insightful. And I'm really indebted, thankful to Dr. Deep Dutta and Dr. Rajiv Singla. And I'm also very thankful to Dr. Rakesh Mishra, the national EP member for IIP, Central IIP, and he's joining from Bhopal. Thank you, Dr. Rakesh Mishra, for joining today's webinar.
All my pleasure,
also,
sir.
Also thankful to Dr. Vikas Malhotra. Dr. Vikas is a practicing pediatrician in Aligarh. I'm interested in childhood diabetes, and thankful for his inputs today. And we have also Dr. Ajay Kumar Gupta, past student of IIP Delhi here joining the session. I'm really thankful to Dr. Ajay Kumar Gupta also. And we have Dr. Vipul Jain, the man behind the show, looking after all the logistics, all the planning of the events. And today was the 7th session. We have a few more to go. And in the last, I would like to thank all the delegates who have attended today's session, who are making these sessions really successful by attending. We're looking forward to more insightful session, more knowledgeable session in future. And thank you, everyone. Thank you, sir.
Thank you.
Thank you, Dr. Mukesh.
Have a good
Thank
day.
you,
Dr.
Thank you,
Mishra.
everyone. Thank you.
Thank you.
Bye-bye.
Thank you, sir.